All right, good afternoon, everyone, and welcome to the Center for Community Engagement and Health Innovation at Community Catalyst to our fourth annual Speak Up for Better Health Awards. I'm Brandon Wilson, the Senior Director of the Center, and I'll be serving as your host and facilitator of our award ceremony and discussion on advocacy and equity. For housekeeping reminders, please remember to mute yourselves. Friendly reminder that this webinar is being recorded and will be available for viewing later and for sharing amongst your networks. While the chat function is on, in case you'd like to come in and engage with each other during the webinar, if you have any questions, please submit them by using the Q&A feature, and we'll do our best to answer all questions, but please extend us just a little bit of grace if we're unable to get to every comment. If there are any tech support needs at all, please send an email to Mike Brand or to Sheila Phillips, and they'll be happy to assist. If you find any moments during today's webinar inspiring or worth sharing, I'm confident that you will, please be sure to use the hashtag BetterHealthAwards. Community Catalyst, here we are really uniting towards health justice. We're also building what I'm glad that you asked. We're building the power of people to create a health system that's rooted in race equity and health justice, and a society where health really is a right for all. We fundamentally know and believe that we can build it. If I can borrow some of the words from our executive director, Emily Stewart, she puts it this way: from our very beginning, Community Catalyst has been an organization striving to build unity and connection, and not just between organizations, but between people. People who share in the belief that not only must things change, but that they really can change. People who believe that big things really can happen, especially when we work together. We do this work through our core initiatives, one of which is health systems innovation. In order to innovate and transform our health system so that it is responsive to everyone, every community, to those who need it most and those who are often harmed by the status quo, we know that this can be done when it centers people and communities. A part of our work is to bring lived experience, that's the needs and experiences of people, real-life healthcare, situations and stories, in people's own words and their own realities, to the forefront of health innovation, to ensure that we're delivering better care, better value, better health for every community. That is why we're so excited and honored to highlight the work of our fourth annual Speak Up for Better Health Awards honorees and winners. It's our opportunity to celebrate the everyday people who make our health system more equitable and responsive. These are incredible individuals who are using their voices to make our health system more just and equitable, again, especially for those who are most hurt by our health system today. The fourth annual Speak Up for Better Health Awards saw the nominations of people who brought COVID-19 testing, diagnosis, treatment, and vaccination resources to underserved neighborhoods and populations, particularly communities of color. Those who launched or led grassroots efforts to educate and engage the health system or community needs, particularly related to historical and structural racism in healthcare. Those who advocated for action from health systems on the social determinants of health, like affordable housing, better transportation services, or greater food security in low-income communities. And those who push for education and resources to help people avoid and overcome crushing medical debt. We'd like to take this time just to thank all of our judges, was Demi Chain, Dr. Joya Perry, Jamie Dickerson, Marcus Escobedo, Colin Killick, Monica Valdez, Lupe, and Alan Wow. Now for the moment that we are all here, the presentation of our honorees and our winner. Could we advance the slides, please? One more. Okay. First we have Lucky Alexander Fuller. Lucky, I'm sorry, is a passionate advocate and a member of the Los Angeles LGBTQ community. Lucky launched his organization Invisible Men on Trans Day of Visibility for one very important reason. After he medically transitioned, Lucky found that there was no place for trans men of color to be visible in the media or online. He created a platform for folks to tell their story in their own words. The legacy or the storytellers make up an integral part of the National Invisible Men community. When COVID-19 hit, Lucky and Invisible Men pivoted to serve their LA community in new ways. They created Vax to the Max, a 6-part series of COVID-19 vaccination events that also offered much needed socializing elements and other health resources. They had a DJ, food boxes, self-care kits, HIV testing, and job information. The team created a safe and affirming environment for hundreds of trans men of color to get vaccinated. Lucky encourages everyone to read their stories of the legacy and truly see the trans community. He said, I want them to see the diversity, the different sexual orientations, struggles, and how we thrive. I want them to see the humans, because just existing and being visible is advocacy. I should also highlight that most recently, Lucky completed an all Black Lives Matter mural in Hollywood. So Lucky, thank you. We're all extremely grateful for your advocacy. Our next honoree is Dante. Dante is reimagining community health work by merging his mission in sexual health and HIV education and his love for fashion. Dante created Role Models, a peer influencer model approach that combines traditional public health education events with social networking campaigns and dynamic fashion events to excite, engage, and educate. Dante believes that celebrity social influencers can play a huge role in health and HIV advocacy. He said that if Beyonce, hey queen, or Michelle Obama go on social media and say everybody should wear condoms, people would listen. We always have to find innovative ways to break down stigma and engage people. Systemic barriers to health equity remains a challenge, but Dante feels proud to be walking in the footsteps of resilient and committed advocates who came before him. He's also thinking big. He envisions creating a series of fashion health fairs on a global scale, partnering with major fashion houses to bring health messaging into their public campaigns. One of Dante's big dreams is to work with a fashion house like Versace or Saint Laurent. Dante, we also believe in making no little plans. So thank you also for your tireless or untiring service. Next, we have Abdi Fattah. Growing up on the Horn of South Africa, it shaped his perspective on health and disease. Malaria is very common in East Africa, and when you see people going through those hardships firsthand, you just want to prevent that from happening to others, he states. Ever since he received scholarships to study public health at the University of Washington, Abdi Fattah has made a promise to himself to give back to the community and prevent it. And prevention is always better than a cure. So that's where he's focused his work. Throughout college, he was a volunteer with the Somali Health Board, which has a mission of reducing health disparities in Kings County, largest Somali community. The board works primarily with the Somali community, but also serves other immigrant, refugee, and BIPOC communities, providing essential services and promoting health equity. After graduation, he became its full-time events and outreach coordinator. During the COVID-19 public health emergency, his work has been relentless with testing and providing events that's protected tens of thousands of community members. But his outlook is positive and expansive. His next goal is to get his master's degree in public health, and he plans to continue to improve public health and health equity in the Somali American community and beyond. Thank you so much for all the work that you do for your community, seen and unseen, Somali as well as beyond. And now for the winner of our 4th annual Speak Up for Better Health Awards, Sarah Schwegel. Sarah is no stranger at all to telling her own story. She has been a passionate advocate for disability rights since the age of 6, when she was chosen as the National Goodwill Ambassador for the Muscular Dystrophy Association and began traveling the country, meeting with sponsor organizations and sharing her experiences. Now all grown up and living her best life, Sarah is still deeply involved in disability policy and advocacy through the recent work as a leader and community organizer at Paraquad in St. Louis, Missouri, and her current role as President and Outreach Coordinator at Festibility, a celebration of disabilities, which celebrates the disability community through education, empowerment, and unity. Sarah states that we're trying to make St. Louis, and honestly, the whole country, a more accessible place. Her innovative leadership created remarkable results in 2021. Missouri's Consumer-Directed Services Program, that's the program that provides services and supports that allow people with disability to live independently. It was slated in the governor's recommended budget for a 7.5% cut. Such a reduction would have put many people in Missouri at risk of losing access to this vital service, and with it, their independence. A client of this program herself, Sarah fought back. She launched a statewide campaign featuring partnerships with local universities, media engagement, and facilitated discussions between advocates and decision makers, creating an enormous coalition of advocates and disabled Missourians. As a result of these efforts, the budget cut was not only avoided, but the state actually considered an increase in funding. To educate the community about health equity issues, Sarah is always seeking new ways to lift up the voices of people with disabilities. She recently produced an art show in which 21 disabled Missouri artists who use Medicaid or Medicare told their stories of navigating the system. She states that she's really excited to continue sharing this work and letting people know how important Medicaid is in removing those stigma. Sarah views working with fellow advocates as a critical strategy. She states we have power when we work together as a community. When we have more voices and more power, that's when change happens. Sarah, a huge congratulations to you. And sincerely, thank you so much for all the work that you do. If we can, see you there now. So Sarah, I would like to start first with a question for you before we bring on board our guest, Liz. Our first question, Sarah, if you could tell us, one, what does this mean to you? As well as take a minute and describe your journey into this work as an advocate and your commitment to health equity.
Sure. Thank you so much. This is a huge honor to be able to receive this award for leading the community in such important work. The funding increase that was considered, unfortunately, was line item vetoed by Missouri's governor. But we were able to educate elected officials about home and community-based services and show them what disabled people are capable of, and our collective efforts and success had proved that we have the power we have when we work together, our stories, share our stories, and take a seat at the table, whether we're wanted or not. I want to shout out to Bree at Paraquad and the amazing team there for helping rally all of the other centers and every group that shared their stories, as well as Stacey Westbruce and the OT students at St. Louis University for diving in and working with advocates to uplift their stories. I have been an advocate my entire life. As you mentioned, starting at age 6, working with the Muscular Dystrophy Association, where I really just told my story to help educate folks and understand what people with disabilities are capable of doing and able to do when given the proper supports and resources, we can succeed. I have had many experiences working with historically oppressed groups, and starting in college and attending the National Council on Independent Living conference really made me realize how intersectional disability is. And we're not going to be able to get equity and health justice for everyone if we don't include everyone's voice. So it's really important to me that we are able to lift each other up and support each other within our community. I have been using social media to do a lot of advocacy, and that is what I can attribute this success to. All of our advocacy in 2021 was done via social media, and without being able to build a network and community there, we would not have gotten that funding increase included in the budget. So really great work, everyone who helped on that project.
Thank you so much, Sarah, and congratulations again. Because we strive to curate spaces where we bring together policymakers and advocates to spur community-driven approaches to health systems innovation, where we center lived experience, underserved communities, and those who are often hurt or harmed by the health system, we are so happy that we have Liz Fowler, Director of CMS Innovation Center, joining us today. Liz is the Deputy Administrator and Director of the Center for Medicare and Medicaid Innovation. Dr. Fowler previously served as Executive Vice President of Programs at the Commonwealth Fund and Vice President for Global Health Policy at Johnson & Johnson. She was Special Assistant to President Obama on Healthcare and Economic Policy at the National Economic Council. From 2008 to 2010, she was Chief Health Counsel to Senate Finance Committee Chair, Senator Max Baucus, where she played a critical role developing the Senate version of the Affordable Care Act. She also played a key role drafting the 2003 Medicare Prescription Drug Improvement and Modernization Act. Liz has over 25 years of experience in health policy and health services research. Her bachelor's degree is from the University of Pennsylvania, a PhD from Johns Hopkins Bloomberg School of Public Health, where her research focused on risk adjustment, and a law degree from the University of Minnesota. She is admitted to the bar in Maryland, the District of Columbia, and the U.S. Supreme Court. Liz is a fellow of the inaugural class of the Aspen Health Innovators Fellowship and a member of the Aspen Global Leadership Network. I've had the pleasure of working closely with both Sarah and Liz on issues ranging from health equity to care coordination and lived experience and social determinants of health. So this will be a treat. Let's keep this conversational and feel free to ask each other questions if you'd like. So since I've already asked the first question to Sarah, Liz, I'd like to offer you the opportunity to share with us. Given the nature of our work, sometimes there's a yin and yang, a push and pull, collaborative and activist between policymakers and advocacy. Can you tell us why it's important to include the voice of advocates and community members of Sarah in the way you think about improving our healthcare system?
Thanks, Brandon. Before diving in, I just want to thank Community Catalyst for inviting me to speak with you today. I have a tremendous amount of respect for Community Catalyst and everything you do, and also want to offer my heartfelt congratulations to Sarah on her well-deserved reward. Listening to your remarks, I can tell what an impact you are making and have already had through the course of your life and your advocacy. And it really is advocates like you that drive the work that we do and ensure that we center lived experience throughout the policymaking process. I'll just say when I arrived at the Center for Medicare and Medicaid Innovation Center, sometimes called CMMI or CMS Innovation Center, we undertook a strategic refresh to learn what was working well and where we needed to improve. And one thing we learned through this process was that we really needed to recenter the patient experience in our work. We spent a lot of time over the last 10 years talking to healthcare professionals, payers, academics, but patients were noticeably absent from the conversation. And when patients aren't centered in policymaking, we see the result: an uncoordinated, highly complex healthcare system that fails to meet the needs of the people it aims to serve, and especially those from historically underrepresented communities. I know many of us here experience the difficulties of navigating this highly complex system, and just sharing a few numbers that I find compelling. Over the last 20 years, fragmentation in healthcare for people on Medicare has increased exponentially. Between 2000 and 2019, the percent of beneficiaries seeing 5 or more physicians annually increased from 17% to 30%. And even more startling, we've seen an 83% increase in the number of specialists a primary care provider needs to coordinate with on behalf of their patients. This means that patients, people with needs, have multiple providers, receive duplicative and unnecessary services with potential out-of-pocket costs for each service, and no single provider who's coordinating their care. The CMS Innovation Center envisions a health system that achieves equitable outcomes through high quality, affordable, and person-centered care. And if we really want to make this vision a reality, we need to keep patients at the center of everything that we do.
Thank you, Liz. Sarah, I would like to ask you a similar question. Why is it important for policymakers to hear directly from community members as yourself?
Yeah, thank you. So nothing about us without us is one of the biggest phrases within the disability rights movement. Sure, you can have experts that know all about disability and, you know, have worked with many people with many different disabilities, but until you've been stuck in bed waiting for your wheelchair to get delivered because you are waiting for insurance approval, or until you are filling out paperwork that is asking you how much cash on hand you have in your wallet right now, or explaining your personal hygiene routine to a stranger that you met 15 minutes ago while they're inside of your home, you don't know what it's really like to be disabled. So having folks with disabilities at the table, part of the discussion, helping influence those policies, that's going to be what makes it better for everyone. No one is trying to, you know, get personal care assistance because they feel like it and it's easy and like a quick way to scam the government. It's hard to do. You need it for a reason. We need to be at the table.
Thank you, Sarah. If I could ask you a follow-up question. If you could only choose one, what would you think is the most important thing you'd want policymakers to know about how to make the health system work better for you?
So people with disabilities really just want the same American dream that every other American wants and hopes to have. And without those support services, such as personal care attendants, coverage for durable medical equipment, and complex rehab technology, we aren't going to be able to do that because we need those extra supports. So if a policymaker can do any one thing, it is make sure that policies account for additional support needed for disabled people to succeed in their lives, whatever path that might be.
Yeah, Sonic, you just described equity to me.
Yes, basically.
Appreciate it. Lance, if I can turn back to you. Can you tell us what the work, or more about the work that you lead at the Innovation Center, and why that work is important for people in communities? For example, make it really plain for us. What are innovation models? What's accountable care? And how does that translate to value to people?
Sure. I'll start with a brief overview of CMMI and accountable care organizations, and then tie it together with a brief patient story. So the Innovation Center was established in 2010 as part of the Affordable Care Act, and the goal was to test new approaches to care delivery and payment to improve the quality of care provided to Medicare and Medicaid patients without increasing spending or without harming quality. Essentially, you can think of us as the research and demonstration arm of CMS, the Center for Medicare and Medicaid Services. And this means that the center in our work can change the way that we pay for services, that Medicare pays for services, and then evaluate whether that change improves quality or reduces costs. One example of a model that can improve patient care is an accountable care organization, or an ACO. So I'll talk a little bit about that. We've just talked about, and you've heard from Sarah, how difficult navigating the health system is and how complex and difficult it is for anyone, and particularly people with multiple chronic conditions, maybe people with a disability, and those who receive, anyone basically who receives care from more than one physician in different specialties. The fee-for-service payment system in traditional Medicare doesn't really provide a mechanism or a means to facilitate care coordination. In fact, sometimes these payment mechanisms work against efforts to coordinate care. And this is where an ACO can play a role. In an ACO, physicians and other healthcare providers join together to take responsibility for quality of care that their patients receive and the total cost of that care. These responsibilities encourage providers to coordinate services around clinicians and care setting using a team-based care approach. The rationale for ACOs, in short, is to improve the healthcare experience for people and the delivery system for providers, as well as the Medicare program. To tie it all together, I'll share an example of an accountable care organization in one of the CMMI models of what care can look like for people in an ACO. And this is the story of a person on Medicare who's 90 years old, homebound with multiple chronic conditions, and who required assistance for activities of daily living. He was experiencing depression, anxiety with insomnia, poor appetite, and shortness of breath. His care strategy under the ACO included in-person home visits, telemedicine visits, quick phone visits conducted by 2 providers and a community health worker. And together they addressed his reluctance to depression medication and therapy, including helping him find a language therapist who shared his language, as well as hearing aid batteries and help with SSI benefits. And the outcome of this patient-centered home-based care was avoidance of emergency department visits through more intensive monitoring and support, which was really achieved by building trust with the patient to address his underlying conditions. All patients should receive this type of patient-centered coordinated care that's really focused on their needs and focused on getting them well and staying well. And we know that this type of care is more likely to happen when a patient is in an accountable care organization.
Thank you. That was really, really helpful in understanding the importance of the work that's done at CMMI. If I can ask a follow-up question, Liz, and I think you addressed some of it, but just want to explicitly ask it. Oftentimes, people, when they hear about addressing the costs or Medicare solvency, and when they hear terms such as value-based care, they often hear they're cutting back on my services, or it may be declining access or quality. How do you think about striking that balance? Or how do we tell people in simple terms, what does it mean, and what does it mean for their access and quality of care when we address costs?
It's a great question, and we get that question a lot. If we want to keep Medicare solvent, we have to start paying for better access to services that lead to better health outcomes for people and improved quality of care. And this shows why the transition to value is really important. In addition to improving healthcare quality and patient experience through better care coordination, we're also trying to bend the cost curve of health spending by reducing readmissions to the hospital, reducing unnecessary care, or eliminating low value care. The patient I just mentioned, for example, avoiding admissions to the hospital that were really unnecessary, that could be handled by regular communication, by telehealth visits, by appropriate care, by coming to his home and visiting him in the home and making sure he's getting the care that he needs. All of which I think we think this can be achieved in part by elevating the role of primary care and providing incentives for care coordination and accountability for quality.
Thank you. Sarah, back to you. Have you found, I think you mentioned it, but just to ask again, have you found anything to be most effective in how you engage with others in your community that's allowed you to be an effective and consistent voice for improving quality and experience?
Yeah, so I think social media is a really, really important and helpful tool. However, I think that it definitely also has its drawbacks and is not always the most accessible. So for me as an organizer, it's really important to make sure that the information I share with the community on social media and the opportunities that I can present on social media are also available in real life and in a lower tech space. A lot of folks with disabilities may not have access to social media depending on their income levels and if they can afford internet. Some elderly folks who use Medicare and Medicaid services, they might not be comfortable using social media. So making sure that there's multiple avenues of communication and connection within your community, and then making sure that those avenues are accessible as well. So having image descriptions, ASL interpreters, captioning, audio descriptions, all of that is really important and the best way to keep your community engaged, because if they know what you're producing is going to be accessible, they're going to be more comfortable coming and engaging with you.
Thank you. Liz, I have a similar question for you. But as I mentioned at the start of our program, that we at Community Catalyst, that we are on a journey and one is towards becoming an anti-racist organization. In this, we do center our work in race equity and health justice. Can you speak to the equity journey of CMMI and how do you see engagement of communities and organizations that are maybe not direct healthcare providers, such as the advocacy community? And how do you include us as part of that equity journey?
Well, thanks, Brandon. And I'll just start by saying I mentioned that when I joined the Innovation Center, we launched a strategy refresh, and we identified as part of that effort, advancing health equity as one of our 5 strategic objectives. And you might recall as an alumni of the Innovation Center, that when we looked back at a lot of the work we had done, we weren't able to say whether we were actually improving care for underserved populations. We either weren't collecting the data, we weren't doing the evaluations, we weren't really thinking intentionally about how to address health disparities and advance health equity as part of our mission. So we have made a commitment to embedding health equity in every aspect of our models and really increase a focus on underserved populations. We are implementing socio-demographic data collection and reporting requirements in all of our models. We're requiring all of our model participants, these are often like hospitals and health systems and provider organizations, to submit a health equity plan. Tell us how you're going to reduce disparities that you see in your populations. We've incorporated screening and referral for social needs and created innovative payment mechanisms to support providers that care for underserved populations. We will continue to do all of this work in incorporating health equity in our model design and evaluations. And we're continuing to collaborate across CMS and other parts of the government to make sure that we're finding ways to increase safety net provider participation in our models. In terms of the advocacy community, you need to hold us accountable. You need to be able to look and see, do you see the results from your work? Do you see your priorities reflected in what we're putting out there? And if not, hold us accountable. Come, let's have that conversation, because we've challenged ourselves to be really intentional about this work, and we want to make sure we don't lose sight of that. And I think there's a definite role for the advocacy community to make sure that we're living up to that promise.
Thank you for that invitation. We will be there. I do have a question for you, Dr. Fowler, from the chat. It says, how might one use principles of human-centered design in designing health policy interventions for ensuring equity and social justice from an inclusion standpoint?
So in terms of human-centered design, I think one of the things that we're thinking of doing in our models, we have started looking at a patient journey mapping for all of our models and for the areas of care that we're exploring in ways to improve. And so really making sure we're incorporating that patient perspective in sort of every aspect of care delivery. And then thinking about how we can improve that. And Sarah, we've put together also a working group. You know, one of the other things is, as we think about health equity, we don't have any models that are focused on people with disabilities. And so we think that's been a real gap in our work. And so we have a working group now that's thinking about how we might make sure that that patient journey mapping includes patients with disabilities, that we're incorporating that voice, and that the models that we're looking at make sure to reflect improvements for every population.
Thank you for that response, Liz. And I'm certainly happy to hear that there's now a work group looking at how to include persons with disabilities. Sarah, I think that's probably an awesome opportunity for you to tell us. Can you give us just a little bit more insight on what's the Festibility all about, your celebration of persons with disabilities?
Festibility is a disability pride event festival that happens in St. Louis every year. It is free and open to the public, and we are expanding. So our main goals are to celebrate the disability community through education, empowerment, and unity. And really the whole point of Festibility is just to provide a space where people with disabilities can get together with one another, with non-disabled peers and allies, and see all of the amazing things and celebrate all of the amazing things we do. This year, we are bringing in Tony Award winner Ali Stroker, who is a disabled mother and obviously Broadway actress, and she'll be doing a keynote presentation and performance for us. And we will also be having several local disability groups either performing or giving TED Talks or really just sharing anything that they've created. It's a very exciting time for everyone to come together, learn about the resources that are available in St. Louis, and learn about the issues that matter to people with disabilities.
Awesome. Also sounds like an excellent opportunity to socialize this new disability working group coming out of CMMI. I have another question in the chat, and I think this one is for you, Liz, but I think either one of you could speak to it. It says, have you seen or heard of any programs that are attempting to engage patients, and in particular patients with disabilities, and rethinking how their dental care is or could be provided?
Wow, that's a good question. And I don't know if you've seen that this, our administrator, Chiquita Brooks-LaSure, has hired the first chief dental officer at CMS. And Dr. Natalia Chalmers is really thinking about how to make sure that we're doing everything we can for patients in the dental area. And she's been looking for opportunities to expand access to dental care. I think one of our limitations is that there are, it's not necessarily a covered service in Medicare. It is in Medicaid, of course. So we've been somewhat limited in what we can do in that area, but we're exploring opportunities with our partnership in our chief dental officer. But if you have ideas, happy to hear them, but no immediate work in that area right now.
Liz, for those who may not be policy wonks like yourself, who may not understand why it isn't a covered service in Medicare, can you briefly explain that?
Well, Medicare, which was passed by Congress in 1965, was sort of based on what healthcare services were covered in a typical Blue Cross and Blue Shield plan at the time, which divided services into sort of hospital or inpatient services and then outpatient physician-based, office-based care. And we've sort of been stuck with what was put in the law way back then. We've been adding to it, and of course, have continued to iterate on Medicare. We added, for example, the drug benefit in 2003, but imagine that a program for the elderly, for seniors and people with disabilities, did not cover prescription drugs between 1965 and 2003. And I think we've been still trying to add. I think Congress looked at adding dental services when they passed legislation last year, but it didn't make it across the finish line. Hearing aids is another aspect of care that's not covered by Medicare. So I think, you know, there's been lots of creativity in trying to think about how to cover dental care. You can get dental care if you have an emergency, for example, and it leads to a surgery and it happens to be incidental. And I think the administrator has challenged us to think creatively about using those narrow opportunities to, you know, maybe expand a little bit further. And I think we're trying to do that, but there's a limitation in the law and the coverage today. Now, if you're in a health plan, if you decide to join an HMO, they may cover dental services and I think to some extent, but it's been somewhat limited.
Thank you. Sarah, have you heard of any examples in this situation?
I have not really heard of any examples specifically for dental.
Okay, thank you. So I do have another question for you both. This is, do either of you have tangible suggestions or examples of how to utilize data collected that has been disaggregated by race to ensure that this is not just data collected, but rather collected purposefully and actually fuels ways to uplift the lives of those who should benefit? Sarah, I'll start with you.
Okay, so I think from my perspective, I do a lot of story sharing and, you know, ordinal data work. So I think that really just uplifting the voices and making sure that, you know, if you're putting together like a storybook or infographics, you make sure that you are highlighting multiply marginalized folks and sharing their stories and uplifting their voices primarily.
Thank you. And Liz?
You know, sharing stories has become a really important way for us to explain what it is we're trying to do. When you just talk about value-based care or accountable care organizations, or, you know, you use these health policy wonky terms and no one really understands what you mean and they're not sure that it's going to actually matter to them. I think sharing stories of exactly what we're trying to achieve is really important. And you had asked a question, making sure that we're not just collecting data. I think we do want to make sure it's not just about collecting data and being able to share numbers, but actually having strategies behind what it is we're trying to do and goals. So we've set explicit goals for what we want to do to try to reduce disparities. It's not just about collecting data, but it's also about engaging. I see there was a question about FQHCs, making sure that we're working with all parts of the healthcare system, including rural health clinics, FQHCs, safety net providers. I think we're looking for ways of bringing in community health workers. And I think, as you know, Brandon, we've done work in the accountable health communities model that was trying to collect data, not just about race and ethnicity, but also trying to look at social determinants of health and trying to collect information where there were needs of patients and then connect them with community-based resources. And, you know, it's all tied together, all of these things. And I think Sarah said it best when she was talking about the intersectionality of a lot of these different issues. So making sure that we're connecting people to the services they need that actually, at the end of the day, impact their health.
Thank you. And I should lift up that Jody Luke, who is in attendance, actually sent us a great response to a previous question around dentistry. States that University of Pennsylvania and Columbia are both training FQHCs and safety net systems on how to create centers for inclusive dentistry with a focus on disability, and that patients have access to their programs through Medicaid. So thanks for that plug, Jody. There's another question for you, Liz. It says, is there criteria that CMMI uses to screen for health equity?
So I think It's more screening screening, let's see, I guess I would describe it as we make sure that the organizations that are coming into our models are diverse. So we want to make sure that we're bringing safety net organizations in. We are looking at payment mechanisms that hopefully adjust and address some of the historical underfunding in underserved communities. And I'll give you one example, the ACO model that we started this year. We asked and we look at the patients that those organizations serve. And if they're serving a higher proportion of dual eligibles, it's those who are eligible for both Medicare and Medicaid, and we look at area deprivation index. And if they're at the higher end of the spectrum and caring for those populations, we give them an extra payment bump of $30 per member per month. And then if you're at the bottom end and you've got a pretty undiverse population that doesn't include a lot of dual eligibles, and you're in serving areas that aren't really those area deprivation index communities, you get a payment cut actually to make it all sort of balance out. So we're trying to adjust some of those historic underfunding of certain communities. I think that's one way we're trying to do that. I think collecting data, collecting information about social determinants, providing flexibility for payments to be made for services to address social determinants. For example, some of our models allow providers to pay for food and, for folks who might be in need, pay for transportation services. I think we're looking into how we can assist for other aspects of that might impact health. For example, air conditioners, if you live in an area and you don't have adequate cooling mechanisms, if you live in an area that's experiencing very hot weather, that's influencing your health. So I think those are some of the ways that we're trying to embed health equity. I don't know if that answered the question, but just some examples of what we're trying to do.
Thank you. And I have a question. I think this one is for both of you. This is, do you see promising ideas that bring more value to the care or services provided to underserved adults who may be blind or disabled in Medicaid in Missouri or any other states?
Can you repeat that for me?
Sure. Do you see any promising ideas that bring more value to the care or services provided to underserved adults, particularly those who may be blind or disabled, through Medicaid, whether that's in Missouri or any other states?
So this year, there is a House bill that is addressing Ticket to Work, which is a Medicaid buy-in option for folks who need personal care attendant services. I do not remember the number, the bill number, but I do know that it was heard in committee last week. And hopefully will continue through the legislative process. But if that is passed, folks with disabilities will be able to pay into Medicaid on a sliding scale based on their income and maintain their personal care attendant services. And it will also disregard spousal income up to $50,000, which is a big deal because right now, you cannot be married and maintain your Medicaid services if you're a disabled person in Missouri.
Hopefully that passes and helps. That does seem to be a huge barrier.
Yes.
Les, I have one directly for you. Has CMMI considered a permanent advisory council consisting of diverse stakeholders, including beneficiaries and community groups?
Yeah, that's a great question. We've been holding a number of public listening sessions, and a number of those have focused on patient, beneficiary, consumer voices with invited remarks. I think we're trying to look at some regular way of keeping in touch with patient advocates and consumer advocates, we've talked about doing a regular quarterly listening session or just a meeting with folks to make sure we have a regular avenue. So I've got a team that's thinking about what mechanism is the best approach, but certainly something that we're actively considering.
Okay. And do either of you have knowledge or experience with the premise of food as medicine, where providers are able to give their patients a prescription for healthy food to supplement their chronic health needs?
Well, I mentioned that some of our models explicitly allow nutrition, food as medicine, as part of their supplemental benefits. And we've got a couple of models where organizations that are participating with us are able to provide food. What we found is when there's food insecurity, that sometimes just writing out a prescription and giving it to a patient makes it feel more like medicine, even if it's not necessarily food as medicine, but it's, you know, it's part of the benefit that we're providing. So it's definitely, we're looking at ways of doing more of that. I think the White House had a whole session last fall on how to think about nutrition as part of health. And they've challenged us to come up with even more ways. And so we're looking at additional avenues where we might be able to incorporate food as medicine as part of benefit structures.
And Sarah, have you noticed or seen any food as medicine innovations or ideas in your community?
I have not, but would love to learn more about that. It sounds like a really interesting and holistic approach to keeping folks well. So I'm definitely going to look that up.
And Brandon, I think before we go on to the next question, I was referring to Medicare, but I think some of your listeners might know that Medicaid is looking at waivers that allow states to provide food as medicine. I think it's Washington, Oregon, and maybe Arkansas that have approved waivers to allow food as medicine as supplemental benefits in Medicaid. So maybe, Sarah, that's something Missouri, maybe they want to consider, I don't know. But certainly, I think that avenue has been opened, or that path has been opened.
Okay, I have one more, thank you, Liz, for that plug. I have one more question for you, Liz, and then a question for both of you to know we're coming to time. When CMMI conducts research, do they ever work with external partners, for example, private companies, or do they only do research on internal policy changes?
We're very externally focused. I mean, the Innovation Center, we get a lot of ideas, some solicited, some unsolicited, but we meet with anybody who's got ideas. They bring ideas to the table. We don't always take the ideas that come to the table, but I'd say if there's research or anything to share with us, I think the first thing I might recommend is looking online at our strategy and making sure that it's aligned with our strategic objectives, which are accountable care, advancing health equity, tools to support health innovation. I think we're looking at explicitly ways to make healthcare more affordable, and then also partnering with other payers in the system and other, I think the term is partnering to achieve health system innovation. Like, who should we be working with to make sure that the changes that we're testing in our models have sort of a maximum impact?
Wonderful. Last question for you both. So at Community Catalyst, we've been asking partners and staff members alike, what does health justice mean to you? For me personally, it's understanding both social and now also political determinants of health. Having multiple perspectives about health justice is an essential step in understanding how we can address communities' health wants as well as needs, so that we can have a more equitable health system. So now we're asking you, what does health justice mean to you? I will start with you, Sarah.
Okay, so for me, health justice is really about access for everyone. I don't think we're going to have an equitable and just healthcare system until every single person that wants and needs healthcare, that and is able to get it at the level that they need. So I think when I say access for everyone, like, yes, many people have access, but let's make sure what everyone has access to is going to meet their needs. So like that would for me be like, in my ideal world, private insurance would cover home and community-based services, so that I don't have to rely on Medicaid for that.
Thank you. And Liz?
Well, I might take it up maybe and think about it more philosophically. And I think what it means to me is a recognition that healthcare is a right and not a privilege in this country. I think our country many people don't see healthcare as a right, but it should be recognized as a fundamental right, which I think then from there you can say, okay, then what should that healthcare look like? And I think there's been so many changes in the way that we think about different issues. Just in my lifetime, for example, marriage equality is now widely accepted as something that people recognize. Of course, why wouldn't there be marriage equality? Even something like, look at what has changed in public attitudes around marijuana, for example, just in my lifetime. And states that are passing legalization. I know it's not at the federal level. So I think that there is the chance to change people's hearts and minds. And in my lifetime, I would love to see where we have a recognition that healthcare is a right that everyone should have.
Liz, Sarah, thank you both so much. Thank you for the work that you both do, whether it's advocacy or policymaking. We really do depend upon people like you to help continue to speak up and make your voices heard, and work on behalf of the American people, so that we can have a healthcare system that is responsive and accountable to people and communities. Thank you everyone for attendance. Thank you for your time. This will be recorded and available for viewing and redistribution. And look out, I think it's maybe should come either to your inboxes or the next slide, where there will be an evaluation form, and we'll greatly appreciate it if you can take time to complete it. Thank you all.
Thank you.
Thank you.